I'm waving to them. Good afternoon. My name is Janie Gordon, and I'm the Program Administrator of the Mid-Atlantic Public Health Training Center. On behalf of the Training Center and the Maryland Department of Health and Mental Hygiene, I'd like to welcome everyone to today's presentation, our September Public Health Practice Grand Rounds on Influenza Policy, the Impact of Diagnostic Tests and Epidemiology. Before I introduce today's speakers, I have a few announcements. For people who are watching online, please check out our archived Grand Rounds and other online trainings as well. I'd also like to draw your attention to some of our live face-to-face trainings that are coming up, including grant writing, logic models, and community assessment. Our next regular Grand Rounds on October 17th will be about making health reform happen, how Maryland is implementing the Affordable Health Care Act. We also are partnering with the Center for Sexually Transmitted Infection Prevention, Maryland Department of Health and Mental Hygiene, to offer a presentation of the Sexual and Reproductive Health Grand Round Series on October 4th. The topic will be Sex and the Superbug, Next Steps in Dealing with Multi-Drug-Resistant Gonorrhea in Maryland. Also, for those watching online, please know that you can email a question for either or both of today's presenters by simply clicking on the link. We also do ask that you fill in the sign-in form so that we can give our federal funders a better idea of who is watching and how many people are watching today's webcast. With that, I'm going to go ahead and introduce our speakers today, Charlotte Gaydos and Trish Perl. Dr. Gaydos is a professor in the Division of Infectious Disease Medicine, Johns Hopkins University, with joint appointments in emergency medicine, epidemiology, and population, family, and reproductive health, School of Public Health. She's the director of the International STD, Respiratory Diseases, and Biothreat Research Laboratory. She received her BS in Medical Technology and her MS in Medical Microbiology from West Virginia University. Her MPH and DrPH were received from Johns Hopkins University School of Public Health. Dr. Gaydos has extensive laboratory expertise with over 40 years' experience in microbiology. She's authored 22 book chapters, over 320 research articles, and over 500 research abstracts and oral presentations. Dr. Gaydos has conducted clinical trials for new diagnostics for C. trichomonas, N. gonorrhea, and T. vaginalis. She has worked for 24 years in STD research, developing DNA amplification for C. trichomonas, C. pneumonia, C. psittaci, T. vaginalis, N. gonorrhea, and M. genitalium. Her laboratory is the International Core Diagnostic Laboratory and Reference Laboratory for many collaborative studies of STDs, respiratory diseases, and trachoma. She is co-investigator for the Diagnostic Core for the Mid-Atlantic Center of Excellence for Biothreat and Emerging Infectious Diseases. She's the recipient of an NIH Center grant to develop and test point-of-care tests for STDs, which has allowed over 750 persons to perform a rapid self-test for HIV. The laboratory is CAP-CLIA licensed for diagnostic assays. Dr. Gaydos is the director of the North American branch for the International Union Against Sexually Transmitted Infections, serves on the executive boards of the American Sexually Transmitted Diseases Association and International Society for Sexually Transmitted Diseases Research, and serves on the editorial board for the STD Journal. She's chairman of the research committee of the National Chlamydia Coalition. Our second speaker will be Trish Perl. Dr. Perl is a professor in the Department of Medicine, Infectious Diseases, and Pathology at Johns Hopkins University School of Medicine in Baltimore, Maryland, and in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. She is Senior Epidemiologist for the Johns Hopkins Health System in Baltimore, Maryland, and Florida. Dr. Perl received her Bachelor of Arts and Medical degree from the University of North Carolina at Chapel Hill and a Master of Science degree from McGill University in Montreal, Canada. She completed an internship, residency, and fellowship in internal medicine at McGill University, Royal Victoria Hospital in Montreal, and a fellowship in infectious diseases and clinical epidemiology at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. She was the hospital epidemiologist of the Johns Hopkins Hospital between 1996 and 2010. She has extensive practical and research experience in the field of healthcare-associated infections and resistant organisms and is world-renowned for her innovation and research in the field and use of research knowledge in the healthcare setting. Dr. Perl was the 2006 president of the Society of Hospital Epidemiologists of America. In the past, she has served on advisory panels from the IOM, the CDC, and WHO, and been a consultant to the NIH and ARHQ. An active researcher, Dr. Perl has been a principal and co-principal investigator for studies on healthcare-associated infections, bioterrorism, syndromic surveillance, and antimicrobial resistance for the Centers for Disease Control and Prevention. She has authored or co-authored over 130 peer-reviewed articles. In addition, she has written multiple chapters and contributed to guidelines and policies relevant to healthcare-associated infections at the institutional, state, and federal level. Dr. Perl has been funded by the CDC and the VA and industry over the years. Her scientific interests encompass influenza and pandemic influenza planning, syndromic surveillance, surgical site infections, Clostridium difficile, emerging infection prevention, and interventions to prevent healthcare-associated infections and the spread of epidemiologically significant organisms, bioterrorism preparedness, and patient and healthcare worker safety. She is committed to training fellows and others with interest in healthcare epidemiology and has begun working in the developing world to help promote the science of infection prevention. So now I'd like to turn it over to our first speaker, Dr. Gaydos.
Thank you. I'd like to thank the organizers for inviting me to speak today. My half of the presentation is going to focus on diagnostics for influenza. So our objectives today are to talk about what's required for a point-of-care test for influenza, limitations of some of the rapid point-of-care tests that are available, talk about some of the new tests that are available, and then to end with an overview of a new rapid robotic platform called PlexID, which can identify and genotype influenza samples in real time. So what do we want for an influenza test? We'd like it to be sensitive and specific and fast and simple and cheap. We'd like it to meet the World Health Organization recommendations for point-of-care tests that are affordable, sensitive, specific, user-friendly, not too complicated, rapid and robust, equipment-free, and deliverable to the end users. So the current types of tests that we now have for influenza and other respiratory viruses include the rapid tests, which you'll hear in a few minutes are pretty insensitive and sometimes nonspecific. We have the direct fluorescent antibody test, which is rapid, but it requires an accomplished microscopist. We have shell vial and roller tube culture. These are sensitive methods, but they're not available point of care. We have real-time RT-PCR, which is very sensitive and considered to be a gold standard test, but it's fairly slow. You're not going to get it in time to make treatment decisions. We have pyrosequencing, expensive, and we have some of the new PCRs and the flow-through microsphere arrays, but they're rapid and they are expensive. They're not that rapid, though. So we know back when we had the novel pandemic H1N1 epidemic in 2009 that CDC reported that many of the tests that were out there were insensitive. So you can see here's a publication from the CDC showing only a 40% sensitivity using the Binax assay. The DrPH assay also 49% and QuickVue 69%. And not that great for the regular seasonal H1N1s or our H3N2s also. This is a publication in the New England Journal showing the experience with a test by QuickVue, and over 3,000 samples were tested here. This was at the beginning of the epidemic. You can see started in 2000 and this should be 9, starting in April when the epidemic happened, that we only had a sensitivity for which is called at that time the swine origin, but is the pandemic 09 strain, of only 52%. Seasonal H1, there weren't as many samples circulating, but only 63% sensitivity, and our seasonal friend, our normal circulating virus, H2N3, 31%. Published in CID during this time, the sensitivity of some assays looking for the swine influenza virus, 33, Binax 46 for DrPH and 53 for QuickVue. Chris Genosio published in JClin Virology that one of the rapid tests, and they switched in the middle, either Binax or 3M, only had a sensitivity of 21%. DFA, which I mentioned requires a good microscopist, 47%, and the R-mix culture was higher. So we know that influenza is always changing and is always challenging. So we had in 2009, as I just have gone over, the H1N1 pandemic, swine influenza, which took the world by storm, and then as soon as it came, it seemed to go away. It's still circulating, but now this year I want to focus on a new variety that we have, and what are the diagnostics for this organism. It's an H3N2 variant, and it circulated last summer and also this summer. So this variant virus was originally detected in small number of cases in 2011, and now this summer has surfaced again. What it is a recombinant, and it's an H3N2 influenza virus, but of the 8 genes, the M gene or the matrix gene comes from H1N1 pandemic. So it's a mix or a recombinant. This year, there have been 306 cases as of 10 o'clock last night when I saw the last CDC update of these variant infections. 13 states were involved, whereas last summer there were only 12 cases in 5 states. So Indiana leads the list with 138 cases, and Ohio has 106, and you can see here Wisconsin 20, Maryland has 12, Pennsylvania 11, right around in this area, Mississippi 6, Illinois and Minnesota 4, West Virginia 3, and Hawaii and Utah 1. Most of these have occurred in children under the age of 18, however, but there have been some in older individuals. There have only been 16 hospitalizations and 1 death. All of the cases have reported direct or indirect exposure to swine at agricultural state and county fairs. There was last summer 1 report of a few cases of human-to-human transmission at a child's birthday party. Now, a couple of weeks ago, Minnesota Health Department reported that we now have a new variant called H1N2. You know there are 9 N types and there are 16 H types, and I'm sure Dr. Perl will be talking about these. But now, because of the increased surveillance for the H3N2 variant, we've discovered that we have an H1N2, and we now have 4 cases in Minnesota. So the CDC has a RT-PCR diagnostic panel, and the public health labs have this panel. So if you have it, used to be, if you had one that tested positive for A and H3 and pandemic, and it was negative for seasonal H1 and other pandemic H1 markers, they were reported as inconclusive. But however, in August the 7th, CDC updated the results for interpretation, and now the specimens with these findings can be called presumptive. And if they go to the state and health lab, they can be called confirmed. So, as I said, this panel is only available at public health laboratories like state laboratories, and it's not a point-of-care test, and it's not available to clinicians on the everyday seeing patients. So now there are 7 FDA-cleared tests. Remember, the last couple of years ago, there were only 3 or 4. Now we have 7 cleared tests, and they're listed here. We have Binax and Antigen, Flu Alert, QuickVue, a couple of new ones, Sofia and Veritor, and Expect. These are the samples. Most of them do all of the samples, but not all of them. Some of them, for this one example, doesn't do NP swabs. So this is what they are approved to test by the FDA. And you can see over here in this column that most of them don't require any machinery or an analyzer, but the Sofia and the Veritor do. I don't know about the Sofia analyzer, but the Veritor is about the size of a third of a shoebox, and it runs on batteries, and you stick the cartridge right in, and it reads it for you. It's a very nice little test. So what the CDC did, much like they did in 2009, is they wanted to see how well the current 7 tests that are out there that are FDA cleared worked on this new H3N2 variant. And so you can see here on the left all the different strains that they picked for H3N2 from the different states to test. They grew them up in cell culture to about 10 times 4 or 6 organisms per mil, and this was the TCID 50s. So here's the 7 tests listed across the top. Now what they did was make 10 serial 10-fold, or they made 5 serial 10-fold dilutions. So they diluted 10 more dilute by 10 times each dilution, and they made 5. So these columns then show the different strains from the different tests and how many were picked up. So you can imagine that the highest strain would be in the highest concentration, and the 5th one would be the lowest concentration. And so only 4 of the 7 assays out there picked up all of these strains, and none of them picked up all 5 strains. I imagine by the time you got to 5, you were getting pretty low concentrations of the virus. But you can see the DrPH picked up 4 or 3. The Sofia picked up 2, 3, or 4. The Veritor did very well and picked up 4 and 3 of the different strains, and then there's the Expect that also picked up all of the different strains. So these are all slightly different. They're all H3N2 variants, but they come from different states. So CDC recommends that a negative point-of-care rapid influenza diagnostic test should not be considered as conclusive because of the lower sensitivity looking at some of these assays. So if you get a negative test, even a positive test, you should interpret these results in the context, or the broad context, of the circulating strains in your area, the level of clinical suspicion, the level of severity of the interest, and the risk for complications. Clinicians should minimize the occurrence of these false positive point-of-care tests by strictly following the manufacturer's directions, and also you can increase the sensitivity and specificity by collecting the specimen in the first 72 hours of illness, and then confirming these results by sending them to a public health lab. So additional guidance can be shown at the website cdc.gov/flu at the bottom of the screen. You can get more information. I want to switch gears now and tell you about 2 new point-of-care tests that are amplified that just got cleared by the FDA in April. And these are the GeneXpert by Cepheid and FilmArray by Idaho Technology. So here's the GeneXpert. It's rated as CLIA moderate, categorized for whether it's not CLIA wave, so it's moderate not highly complex. So it doesn't require a lot of training. You get your results in an hour. Here's your swab. You put the swab in the reagent, vortex it, and put it into this port. You add a binding a reagent over here, insert the cartridge in the machine and say go, and you have your answer in an hour. Not CLIA wave, so it's not going to be used yet in a doctor's office, but I predict that pretty soon it will be. So this is the way the display goes. You can have influenza A positive, or you can have A and pandemic H1N1. And that means that both of these have to be called positive, as in this example. It has to hit for flu A, and it has to hit for the pandemic H1N1 to be called 2009. And then here you have, you can call out B positive by itself, or you can just call out A, which is not the pandemic strain. That would be like an H3N2. So here's some published presentations that have been shown recently. Denver Children's Hospital experience. They compared it to the Prodessa ProFlu PCR assay, which is FDA cleared, and you can see they got great sensitivity and great specificity. University of Virginia looked at this assay, again comparing it to Prodessa ProFlu Plus, which is a typing, and that was their gold standard, and again, great sensitivity and specificity for flu A, flu B, and also for the pandemic H1N1, which, by the way, is still circulating. There was one article that's been published ahead of print by DeMayo, and you can see that compared to RT-PCR is the gold standard. Xpert Flu, again, performed very well for influenza A, 97 and 100% specificity, and also for influenza B, whereas FDA, the fluorescent antibody, did well, and the Binax and the BD Directogen did less well. So now I want to switch to the FilmArray. This is the Idaho Technologies equipment. It's basically a plastic kind of pouch here, and you put the sample in here, and as soon as you put it in, it's loaded by vacuum into all of the wells for the primers. For the PCR, they actually do 2 PCR. They do one here, a nested, second one here. Everything's closed, so no contamination issues. And then they analyze, there's like 200 spots here that they have. So they usually have like 2 targets for each of the viruses. And not only does this test do the different influenzas, it also can test for metapneumo, parainfluenzas, RSV. So you can see here out of about 200 samples, good agreement. Again, this is with the Prodessa assay, and here's the FilmArray. Good agreement if they were positive, and coming up with good sensitivity and good specificity, except for the adenovirus, at least in this publication. Another publication by Rand, again comparing to another PCR test, the Luminex X-TAG respiratory viral panel. And here that you can see that we got good sensitivity and good specificity for influenza A and B, and also for all of the other viruses. And adenovirus was a little bit better sensitivity here. Pierce showed that it works well in pediatric patients. They took 215 archive respiratory samples, and the agreement for the analytes that both tested for was 98%, and the combined positive percent agreement was 89%, and the negative was 99%. Again, good agreement when you looked at individual influenza viruses here for the positive percent and negative percent agreement. I would draw your attention to 3 excellent reviews that have been published this year in Annals and Clinical Microbiology Reviews, and just this month's issue, the Emerging Infectious Disease Journal, all good reviews about meta-analyses for looking at different point-of-care tests. So the last one I want to talk about is this new test called the Sofia. It's brand new. It's their fluorescent immunoassay. And published in Press, looking at sensitivities of 82% and 77% for A and B compared to real-time PCRs, the gold standard. In this same study for influenza A, they looked at Binax and Directogen, and they were only 54 and 68, so a little increased sensitivity here for this assay. And sensitivities of binacs now and the directogen for influenza B were 62 and 52%. So I want to switch and end with this Plex ID instrument and how it can be used for surveillance. Well, how we normally do surveillance is we wait 2 weeks for CDC to get the sentinel reports, and then they tell us the week and how many of the different kinds of influenza there are. And here is in 2009 showing the novel in the gold here, the orange of the novel H1N1 pandemic strain. So wouldn't it be nice if we had something in real time? This Plex platform that I'm going to tell you about was one of the platforms that originally helped designate that the pandemic H1N1 strain was a new strain, and it was a triple reassortment. When it was put on the machine, it was at the Navy Health Research Center, it was called an A, but it wasn't an H3. It didn't type as an H3 and not as an H1, so it was unsubtypable. So the challenge is to have an instrument that can rapidly adapt to a new genotype to give us some just-in-time diagnostic capability. So this is the platform here. And what this platform does is it combines PCR, and then it takes the amplicons and sprays them into a mass spectrophotometer. And so you actually get the interrogation of many different genes, and you actually measure the numbers of A's, G's, C's, and T's, which are the nucleic acids which make up DNA. So it's designed to be used in real time to track a potential pandemic, and it can do 300 samples in 24 hours. One of their first publications was looking at blinded samples, influenza across the United States that were collected from people's freezers, and it was able to identify all of the H3N2s and the H1N1s, the seasonal ones, and the influenza Bs. Then it came up with a sensitivity of about 96%. So when the pandemic 2009 strain was put into this platform, it was shown to have human, avian, and swine. Didn't call anything, but it called the closest match. So these are the genes that they interrogate: the polymerase B, the nucleoprotein, the matrix, the polymerase A, and the non-structural genes. You can see here that the PB1 gene looked like it had human segments. The NP gene looked like it had swine, as did the M gene. The PA gene looked avian. And the NS also looked like swine types. So when it was then put into the bioinformatics as this is the new strain, after CDC sequenced it and said, this is brand new, we've never seen this virus before, you can see that the Plex ID called them all A California 09. They all agreed with the CDC types. And you can see there's very little variation, very little. Every gene had 39, 32, 24, and 33 nucleotides, the C's, G's, T's, and so forth. So tiny little bit of variation here. But when we took all of the strains in October to December that were circulating in Baltimore out of the freezer, and we put them on this platform, you can see the platform still called them A California 09, still the pandemic 09 strain. They all match the CDC type for the PCR, but you can see a huge amount of drifts. So the yellows were the standard from the previous circulating strains, but you can see that the PB1, the M1, the PA, the NS1 and 2, they all slightly were drifting away from the exact nucleotide count. So this influenza virus changes its coat every few minutes. So we published this in Journal Clinical Virology, and so early in the year, the diversity, the genetic diversity in these 6 genes was only about 10%, whereas later in the year, the diversity was about 70%. So in conclusion, you need to know your rapid diagnostic test, its strengths and its limitations if you're going to use it in private practice, in the emergency department, or in the clinic. Some POC tests, rapid influenza tests, may not work well with all strains of influenza, and they're constantly changing. We do have some promising new point-of-care tests, the Sofia and the FilmArray, and more research will be required to see how they perform as influenza changes. The influenza surveillance typing assay by the Plex has the potential to look at newly assorted, reassorted, and shifted or drifted strains. And that platform can detect all of the H genes and all of the N types. So in conclusion, be aware of the potential of new influenza strains. And after the next talk, I'll be happy to take some questions. Thank you. I'd like to acknowledge Quanfu Chen and also Justin Hardick, who is in the audience, for all of their help. Thank you. You're up.
So good afternoon, and I also would like to thank the organizers. I was asked not to wear glasses, but I can't see anything without them, so we're just going to do it. So I've been asked to talk a little bit about the impact of the epidemiology, and I just would like to say, and follow up to Dr. Gaydos's talk, that this particular instrument that she's talked about was very helpful to us in managing the outbreak in the hospital, because not only did we have novel H1N1 coming out, but we had an outbreak of rhinovirus that was killing children, and we simultaneously had pretty severe parainfluenza. So, you know, from an epidemiologic point of view, it can be very helpful. However, I've been asked to talk about influenza, so I'm going to really focus on that. And just a couple of disclosures. Both actually, Dr. Gaydos and I have funding from the CDC and the VA on an influenza prevention study that is related to masks and not to this talk. And then I have some additional funding that's not at all relevant to the talk. So today what I'm going to talk a little bit is some of the epidemiology and disease burden, the information we get from diagnostics and good diagnostics, the impact a little bit, and I'm actually going to focus on the healthcare setting just because there's interesting policy change that's going on not only nationally but at Hopkins. Talk a little bit about our options for prevention and how that's impacting policy. So just to remind you, influenza is an acute respiratory disease. Characteristically, we see a very abrupt onset of symptoms, but all of us will tell you that it's very chameleon in its presentation, and we can see anything from no symptoms to actually severe illness. The incidence is anywhere from 5 to 20% of the general population, and mortality estimates for the United States alone are 22 to 36,000. Now, that being said, if you look at the overall impact of respiratory disease, of which we all know influenza is a huge chunk, it is a significant contributor to worldwide morbidity and mortality. If you look at the subsegment of healthcare workers, who are very interesting because of our exposure, very much like daycare workers, on average, about a quarter of us have serologic evidence of influenza in any given season. And in general, this group recalls having an influenza-like illness, so respiratory symptoms, 60% of the time, and recalls actually true respiratory symptoms with just the respiratory infection, but maybe not the myalgias, etc., about a third of the time. I'm also going to talk a little bit about the impact of outbreaks, again focusing on healthcare facilities, but attack rates occur in healthcare facilities up to 50% of the time. We can see mortality rates of about a quarter of our patients. And in general, we are the vectors. So the virus, Dr. Gaydos actually showed you some much nicer pictures than mine. But needless to say, this is what the virus looks like. And what you can see, it's a single-stranded RNA virus with a segmented genome. And what you can see on this, if I can show you, is that there are some very important components that help us characterize it. There's the hemagglutinin gene, which is the H, and when we talk about H1N1 and there's the neuraminidase, which is the N. that we talk about. And these are actually very important from a functional point of view for the gene. Dr. Gaydos mentioned the matrix gene, which is actually here, and the N2 ion channel protein. Now, this and the neuraminidase gene also are actually important from a therapeutic point of view. There are 3 types of influenza. You've heard about A and B. Those are the most common types in humans, but you can also see they affect other kinds of animals. These are zoonotic diseases in some sense. B is a human-only disease, and C is actually a disease that is uncommon in humans, so you don't hear us talk about it very much, but it is something we see in veterinary medicine. So I keep on pushing the wrong button. Now, the transmission cycle is actually very interesting, and it's one of the things that epidemiologists as well as basic scientists love about this disease. So the normal host for this is actually waterfowl. And, you know, what's interesting about waterfowl is they hang out with migratory birds. And, you know, their secretions, etc., are all shared. And so that this ends up being a disease that you actually see in migratory birds as well as waterfowl. Now, as we all know, this interface of birds or animals is increasing, and when there are opportunities to share, this organism is perfect to adapt to different animal models. And so what commonly happens is that turns out swine are very interesting because their cells have receptors that recognize some of the avian components of the avian virus. So the swine can actually end up getting infected. Swine themselves also get flu that seems better adapted for just that particular host. But in essence, the pig ends up being a lovely pot to resort these genes. And we humans have receptors that recognize swine flu, as you've just heard about from Dr. Gaydos. And so the virus, again, can resort and then become something that can infect humans. Now, it could be a virus very similar to this variant strain that does not appear to adapt well in the human species and is not transmitted rapidly, but as in the setting of the H1N1, it can actually be transmitted very rapidly. So all of this being said, this actually ends up being very important from epidemiologic point of view because we use this information to characterize epidemics, pandemics, and it's actually related to these components of the influenza vaccine. So the thing that's most important about this is when we start seeing these variations and what we call point mutations, very similar to what you saw, is a drift. And a drift are these minor changes in the same subtypes, and those are associated with the annual epidemics. The shift, on the other hand, when you see the emergence of a new strain due to this genetic ressortment, very much like H1N1, you have a major change and you have a new subtype emerge, and that's associated with pandemics. Pandemics are, however, only associated with Influenza A. We do not think of pandemic with Influenza B. And here's a sort of cartoon of this, and you can sort of see here is the 1918 Spanish flu, which was H1N1, and that strain circulated for almost 30 years. Here's the Asian flu that was the next pandemic, and it was an H2N2, so you can see both the H's and the N's switch. That strain circulates for around 10 years. Then you get the 1968 H3N2. So again, you see you have a shift from H2 to H3. And then that actually strain is still circulating. And what's very interesting, I think, about this is you can really see that with the emergence of our diagnostics and our technology, we really start understanding that there are a lot more strains. I don't think any of us think that this just all happened in 1980. We got better at measuring it. And then here's what happened, so you can tell I had to add on to this cartoon. This is when the H1N1 comes out with the outbreak that we had, and this should actually say it was 2009, 10, and 11 with that particular pandemic. Oh, and this got put in the wrong place, but this is actually what Dr. Gaydos was talking about. You can see that you have actually now 16 H's and 9 neuraminidase. And what I love about this is it just shows you the different kinds of species that these various hemagglutinin versus neuraminidase strains can actually infect. So what about these pandemics? Let me just highlight a little bit more graphically the impact of these. So the Spanish flu in 1918 is kind of interesting. There was a huge mortality internationally, or globally, if you will. And what you see is it was 2 mutations from an avian strain, and both from the H and the N. The Asian flu was actually milder, and you can see there was much less of an impact in terms of mortality, both internationally as well as nationally. Here you have a assortment of 3 novel avian strains. When you go to the next one, you get a assortment of 2 segments from an avian virus. And then this particular virus was assortment. And people argue whether it was 3 or 4 segments, and Charlotte and I have had this discussion before, but again, from an avian strain. Now I'm going to switch a little bit. I want to sort of talk a little bit about the impact of flu. So these are common complications in low-risk groups. So you can see in children, they get otitis media, which are ear infections. In adolescents and adults, you can get respiratory infections, just both upper and lower respiratory tract infections. So you can see these complications are 30 to 40% and about 20%. These do not necessarily mean bacterial complications. These can be viral complications. There is well-described bacterial superinfection that also complicates this viral disease. So just as I said, we can see primary as well as secondary bacterial pneumonias. And we also see non-pulmonary complications, which you may be less aware of. You've probably heard of some of the toxic shock associated with the bacterial infections of Staph aureus and probably Reye's syndrome. But part of the picture I want to paint is some of the morbidity and mortality associated with this disease. I mean, people, I think, are a little bit cavalier about how serious this disease can be. So the average person in this room may be into bed 5 to 6 days. When you truly have the flu, you feel like a truck hit you. And some people actually need almost 10 days to recover. From a workforce point of view, on average, people miss 3 days of work, and up to 50% of these people require medical care. This costs $30 billion to the U.S. economy. And if you can see down here, these are the rates of hospitalization based on age. So you can see in young children, the rates of hospitalization are extremely high, as are those in the over 65-year-olds. So a lot of morbidity. In terms of mortality, I just want to sort of put this in perspective for you. These are vaccine-preventable diseases in adults. Here's colon cancer, breast cancer, and I'm sorry this got moved. But influenza is right in this range, and you can see that this particular illness contributes significantly to the mortality in the United States. I'm sorry, excuse me, I went backwards. Now, what happens with illness in households? Well, here's a lovely study. They looked at almost 400 index cases. They had a lot of household contacts. And they had about 40% secondary cases in a household, and about 60% required a visit to the healthcare facility. So a lot of transmission within closed settings. And this is another study actually associated with H1N1, and here what you see is the secondary transmission was lower, only 13%. In this particular group. But I thought what was interesting is that contacts under 18 were almost twofold more likely to get the disease than those over age 50. So there's some immunity that we knew occurred in people over 50. And those that were greater than 50 were less susceptible than those age 19 to 50 by about 83%. And the mean onset was 2.6 days, and we can argue about whether or not that reflects a reasonable period of transmission. I mentioned this statistic earlier, but I just want to reiterate what happens in healthcare workers. I said a quarter of them get influenza, but what is important is about 80% of us work while we are sick, on average 2.5 days, and I already gave you that statistic, and here's sort of that summary information for what I just mentioned. So we have a culture of presentism in healthcare, and remember that we are interfacing with those vulnerable patients that I just pointed out were the highest risk to get hospitalized. Now, who gets it in healthcare? This is a great study from Columbia, and they looked at almost 7,000 healthcare workers during 2009. They had 123 confirmed cases among those people. And the people who were at highest risk of acquiring H1N1 were those in the emergency department and among actually providers, so people who are actually giving care, not necessarily the people who are cleaning the rooms, etc. So it makes total sense. What I thought was also interesting is almost 50% of the illness occurred in less than 20% of healthcare workers. So we can actually really target who is going to get it. And they're highly exposed. And the other thing is they don't listen to people like me, and they don't use their precautions. All right, and then the other point about healthcare that's important is what happens when we have outbreaks. Here is one outbreak that was reported in an AIDS unit, and what you can see are here your clinical diagnosis in orange and your laboratory diagnosis is in blue, but the important point is that you had tremendous influenza attack rates among the patients, almost 35% and 50% in the healthcare workers. So that's what I'm going to tell you about the disease and the epidemiology. And there are multiple options we use for prevention and control of this. You've heard about surveillance and how we integrate that. I'm going to talk mostly about immunization, a little bit about hand hygiene, because you can't ever have a hospital epidemiologist who doesn't talk about that. But I don't want anyone to walk away with this from not thinking that respiratory hygiene, avoiding people who have illness, and there's not a role for antivirals in this illness. So what about the vaccine? So the vaccine estimates are anywhere from 50 to 90%. It's estimated to be a better vaccine in children than in the elderly, and there are many confounders in these vaccine studies that have given this wide range of efficacy. We do know the efficacy decreases when the vaccine strains don't match what is circulating in the community. And one of the more interesting thoughts that's come out of this is, Dr. Gaydos sort of showed how strains emerged or changed, evolved over the 2009 pandemic season. People think if they get flu again late in the season that their vaccine is not efficacious. That's not what we think is going on. We think the strain has changed. Now, this is one of those diseases where there's a lot of argument about what the vaccine does and doesn't do. But what I can tell you it does, there's a new study that just was released this week that shows it decreases Cardiovascular mortality, 75 to 80%. If you're a solid organ transplant, you have a better chance of keeping your grafted kidney or other organ. It decreases pneumonia and hospitalization in the elderly and people in long-term care facilities. And in the people in this room, it decreases febrile illness. So it works. Now, what is interesting, and the point I want to make about this, is we can look at data and surveillance data and change our policy. And this is actually mortality in children over time. So you can see 2004, 5, 6. Here's what happened in 2009. Now, what happened as a result of this mortality? Anyone know? What happened is that the ACIP changed the vaccine recommendations and started recommending this vaccine for any child over the age of 6 months. Last year, we had 23 pediatric deaths in the United States from influenza. That's it. So this is actually one example of how these data impacted public policy. Now, why and what? Why are they doing this? Well, here's another lovely example. This is a cluster randomized clinical trial, 940 children who received flu vaccine and about 2,300 other members of the community who did not. Now, these are heterorite communities, which are very insular communities. They're almost like the Amish, and they live in northern Canada. And what's interesting about this study is 83% of the children who received flu vaccine, and those in the other communities that didn't get flu got a hepatitis A vaccine. The influenza infection rate was 10% in the unvaccinated and 5% in the vaccinated. But what you can see down here, here's the direct effect. Here is actually the herd effect. So even though the adults were not vaccinated, there was a decrease in mortality. And so that also has been a finding that's driven this policy in terms of looking at mass vaccination. Probably the most interesting experiment was in Japan. And here what they did is they looked at their impact of a mass vaccination program. So here's mortality rates for pneumonia and influenza beginning in the 50s. And here is Asian, orange line is Asian influenza deaths. All-cause mortality. And so what you can see is here was mortality, and it goes down. Now, in 1962, they began a program to vaccinate school-age children. And in 1977, it becomes mandatory. They see that they're impacting mortality both from flu and from other. It becomes mandatory, and over 10 years, it goes down. What happens in 1987? It's about the time that the Wakefield report comes out. There is this reaction towards vaccination. They back up on the policy, and look what's happened to their mortality rate, and they're actually in the process of rethinking this national vaccination program. Now, you can say, well, we don't believe it, but I'm telling you, they've done the same thing in Ontario, Canada. It's, there's ample data to show this. All right, so now I'm going to switch a bit. This is kind of the hot thing that's going on. I'm going to talk about influenza in healthcare. So this is how effective the vaccine is in healthcare workers, as a study done at Hopkins Hospital. Reduces influenza 88%. Sick days, about a third. Lost days from work, 40%. There are now, I only show you 2, but there are now 4 studies that show it decreases patient mortality by 40%. Neither Charlotte or I can tell you very many things we know about in the hospital that decreases mortality by 40%. It decreases nosocomial influenza. Here's your proportion of influenza that's nosocomial acquired, and here's the proportion of healthcare workers that get vaccinated. And it turns out that while hand hygiene is good, it's probably not good enough alone. It still is not the primary mechanism of reduction. So there's also a problem with healthcare workers. Only 40% get vaccinated, and there are a whole bunch of reasons why they don't. They're worried about the side effects. They don't think it's protective. They dislike injections. The people who got vaccinated thought it was protective and were worried about the risk of contracting flu in the healthcare setting. So there are a lot of reasons why this group don't get vaccinated. And the other thing is that there's a bunch of data that shows that we can educate you, we can beg, we can have mobile carts, we can bribe, we can do all kinds of things, and we can't get vaccination rates in healthcare above 68% unless we do one thing, unless we mandate it. We require it for you to work in a hospital. And we have just implemented this at Hopkins in all 6 of our hospitals. This is what happened at Washington University when it did it. You can see their percent vaccinated over time. They tried a bunch of stuff just like we did. They begged, they cajoled, they gave prizes, and they couldn't do it until they mandated it. And there are a lot of people out there that actually agree with us, and multiple professional organizations have said we should mandate this vaccination. What's the rationale? It's highly effective. We work in a very unusual environment, but one of the tenets is that we first should do no harm. We also have a public mandate to actually be able to care for people, so we have to reduce our absenteeism and preserve healthcare capacity. We have to protect people who actually work over there so that they don't take these illnesses home to the people they work with, because I've already shown you they're highly exposed. So there are a lot of there's a lot of rationale for doing it. It's not just to be difficult and obstreperous. It's actually there's a rationale behind it. So what I'd like to just sort of end with is here's what's in this year's vaccine. This is not only in North America but also in Europe. So you can see we've got the H1N1, we've got an H3N2, and that there is an influenza B component. Yes, we do have chemoprophylaxis, but I just wanted to tell this group that we have almost lost this drug entirely at this point. There is so much resistance right now that we are focusing our efforts on these drugs, and there is some resistance developing in these drugs. So we're trying to preserve them because they actually are very helpful. So what are my take-home messages? My take-home messages are that influenza is common, including in healthcare workers, and we serve as one of the examples of what's happening in public policy and how epidemiology has influenced that. This is a bad disease. It can be a very mild disease, but it can be a bad disease. The vaccine is, I didn't really tell you it was safe, but it is relatively safe and effective. The epidemiologic data recently has really influenced policy. I mean, to see the shift in the past 5 years is amazing. Mandatory vaccination, while controversial, does remarkably increase vaccine coverage, and it looks, if you do it at a national level, that it prevents mortality. And then finally, just intentions and principles do not protect patients. Results are really needed. And I feel very strongly that not only does that apply in healthcare, but the more I look at the data and the experience in Japan, I feel like it applies to us as a public health community in terms of protecting the nation. So thank you.
I wasn't quite ready for that finish. Now is the time in the program that we can take questions for about the next 20 to 25 minutes. And I want to remind people who are watching online that you can ask questions. You can email questions to either or both presenters anytime by clicking the link on the screen. And for people in the audience, I plan to ask you to wait until our staff member brought you the microphone. She's not here quite yet, so maybe until she comes, if you have a question, you could come up and grab this microphone. And the reason for that is so that the people online can hear your questions. Yeah, it's right here. So does anybody have a question from the audience? You can just grab that, turn it on.
Thank you for your presentation. So I'm Bill Wright. I teach the pandemic influenza course in the school. One of the problems with immunizations are people who have religious objections to the immunization, but the legal status for protecting your own rights against invasion by the government has changed since September 1, 2001. And how do you see the legal landscape affecting your ability to force people to have immunizations within the healthcare community?
It's a great question. It's a great question. And do we need to repeat the question now?
No, that's why we use the mic.
So actually, there is a long history. I mean, I didn't really go into the politics of this, but first of all, I'm going to just point out that I think healthcare is very different than what you do from a public health point of view. But from a public health point of view, I think what we're seeing with herd immunity argues for more of a general approach to immunization for a highly communicable disease. What is going on in healthcare is different. And the first thing that I would just say is that because we work in healthcare, we also are surrounded by vulnerable patients. And many of these patients can't mount immune responses. Because of that, there's almost a different moral imperative, if you will, than in other settings. You have a duty to protect those patients as much as you do anything else. The law around this, at least in the US, and I will probably mix up the names. I could go up to my slides because I put some slides at the end and show you, but there are 3 court cases over the years that actually, in the case of vaccination, have supported mass vaccination. The initial one was in the early 1900s with smallpox vaccination, and there have been 2 subsequent court cases. And this is one of the very few areas where the court actually has supported the Rousseauian right of the public over the individual rights. So I think that that's where the law is. There have been recently around mandatory influenza some challenges, the most famous of which was in Seattle at Virginia Mason, where the nursing union actually sued the institution that was the first one in the country to mandate influenza vaccine. They initially lost. It was repealed, and at the next level of the court, they did at least initially win. It went up to whatever, the circuit court, and then they lost. At that point, what happened is that the National Labor Relations Board became involved and has actually said that in healthcare, this is something that may be reasonable. And so that is changing the argument. So I am not a lawyer at all, but I can tell you that there is at least some case law that supports what we're doing. I also know that there are very, very vocal groups that feel that it's their right not to have vaccine, and I think that it's going to be interesting to watch how this plays over the next few years. whether we're talking about seasonal flu or pandemic flu. So I didn't answer your question, but I tried.
There,
A religion?
My understanding is, at least for a religious basis, you can argue that you have a right not to be vaccinated.
So you can, this was explained to us yesterday, and I will try and summarize, but you actually can object to vaccination on religious reasons, and an employer is required to try and accommodate that. The question is, how much accommodation can they make, and can they accommodate you adequately? And I think that's really going to be where that piece of the law gets tested.
there's a question from online that addresses a different aspect of that issue, which is short of mandating vaccination, have there been others, like which interventions have been the most successful to change healthcare workers' behavior?
Well, on the slide, the examples that have been summarized are the use of education. There have been things like mobile carts that have been tested, which I would argue are just really sort of facilitating access, making it easy to get. That has improved. And those have been the things that have been most successful. Requiring people to decline has not bumped up vaccination rates that much. Sometimes shame actually does it. At Hopkins we have these little things, and I'm going to go get my flu shot because we get a purple sticker this year. But it's almost like the scarlet letter, and that can be very powerful in a clinical environment.
Okay. Any other questions from the live audience? I have another question from online then for Charlotte. What is the status of developing vaccines that are not chick embryo based?
The status of developing vaccines that are not shift-based. Well, we know that the vaccines are based now on the H and N types, which are on the outside envelope of the vaccine, and this, or of the virus. And this is the antigen to which antibodies are made, and has always been the way that we have made vaccines, because these two antibodies to the H and N types prevent the invasion and the spread, the release of the virus. There have been quite a few attempts to make a vaccine based on the matrix gene, which would make it available for all types of vaccines. These vaccines generally have not met yet with great success, because this is an internalized gene, and yes, it's common to all of the different strains, but I think right now we don't have anything that's as effective as the H and N types, and in the future we may see this happen as we become smarter with our recombination and our ability to deliver vaccine.
Okay. Dr. Perl, when you answer, can you get a little closer to the mic because people are having trouble hearing online? There's another question for you, Charlotte. Do you know if the Plex ID is able to identify the H3N2 variants?
Yes, it is. The information is in the bioinformatics in the equipment from the first day that it was shown to be publicized by the CDC website last summer. We have not actually gotten our hands on any of these organisms to test a real isolate. Right now they're being pretty well held tight by the CDC, and so we probably won't know that it indeed works in actual practice until we get one here for us to put onto the Plex. But in theory, it will identify the new variant. It should also identify the H1N2 strain, and it can identify all of the H's and all of the N's. So any major shift, it should call it up even doesn't give it a name yet if it's something new.
Okay. Any questions? Okay.
Hi, I'm just curious. That was a neat story you told about how the viruses were classified as non-typable first before they were, you know, the, what was it called? The presumptive H3N2 variant. So maybe as researchers, if we're, you know, in the process of doing surveillance actively, when we're triaging our data, if we're relying on the CDC
There's another one over here. There's another one. Get a little exercise. Let's see if that one.
Are we, there we go.
Yeah.
So what would your recommendation be for researchers who are doing active surveillance and looking at the results and seeing data that's, for example, you know, non-typable, which they could put in the negative column, but, you know, if you're not connecting that directly in real time with symptoms, for example, you would maybe miss or triage or, you know, throw isolates out, that kind of thing.
So your question is, what should researchers do with aberrant viruses?
Well, I guess it's important from a research perspective if you're doing active surveillance for flu, but it's also important in a hospital setting because until the database is updated, you're just sort of saying, oh, that's not flu, you know, let's look at another virus or other etiology.
Well, the database will always call it flu because it has...
Flu A, right.
We'll call it, there are primer sets in there that will identify any flu, A, B, or C, should we ever get one of those animal C viruses that circulates. It just won't give it a subtype.
Okay.
But right now, because this platform is not yet FDA cleared, we have no other choice but to send it to the public health laboratory at our state level, and then they will do what they can with it with the CDC panel that they have, which has several different PCRs looking for the different components, and then they send them on to CDC. So the hope is that one day when there are more plex instruments around, that we can alert CDC or our state health lab that, hey, something unusual is going on. We have an ability to do pathogen discovery with this instrument. And so it could be an early warning system that, hey, something really is happening, and it might aid our public health officials into recognizing that we are in an epidemic more quickly. But CDC moved pretty quickly on the H1N1 pandemic, and it was a matter of a couple of weeks, and we really knew what was going on. So they're still our gold standard.
Great.
Okay, you want to grab the...
I was just wondering if Hopkins was doing anything to address the low rates of maternal influenza immunization. In pregnant women.
You know, everyone is trying to do something about low rates of influenza immunization, actually in multiple sectors of the population which we consider at risk. You know, I think it's something that we're going to have to work on nationally, just to improve the not only access to vaccines, but understanding of the role of vaccines and their importance. I personally think there's been a lot of damage that's been done by the Wakefield affair, and we are seeing the emergence of pertussis and other illness, measles, and other illnesses that are vaccine preventable. And it's going to be incumbent upon us to really sort of remount our traditional public health vaccines. So people are working on it. They are doing things like vaccinating people when they come in to deliver it doesn't address exactly what you're trying to get at, but I think that we really have to improve access to vaccine and support the public infrastructure to really be able to deal with this in a significant way.
We also know that for the H1N1 pandemic, pregnant women suffered high morbidity. And so I think it's incumbent upon the public health infrastructure to educate obstetricians, to try to get women who are pregnant vaccinated. And it's a matter of public education. There was a lot of public press around this, and I think that's one place where the public press can aid public health is by publicizing this so that people become educated and become more aware that the vaccine is needed, especially in pregnancy, and obese people suffer high morbidity. So we just need to do better at educating the general public. And but even, just because you know something doesn't translate always into behavior change. That's why the mandatory seems to have worked, and we require HIV testing now in all pregnant women, and I can foresee maybe a few years down the road it'll be required that we require influenza vaccination too. Stay tuned.
Any other questions in the live audience? Okay.
Hi, going along with just the public and vaccination, I've noticed recently over the few years now you can get it at the grocery store or at CVS or some drive-through I thought I saw a story of, and how effective some of these maybe newer methods of ease of access have impacted just the general rates of coverage.
The general rates actually have gone up. There was a HHS released a study where they actually looked at the impact of what had happened when they changed the recommendations for the influenza vaccine, and between 2009, 10 and 10, 11, the vaccination rate overall went up from about 30% to 43% or something like that. So it has made an impact, but I think it's like everything. It's going to take time. And if you look at diffusion theory and how things diffuse in populations, we're going to have sort of the early adopters. We're going to have people who sort of follow just because they follow general trends, but we are going to have the laggards that are going to be that tough piece. So I anticipate we'll see our rates increase significantly for several years, and then we're going to have that tough sell in people who really just don't want it, don't believe in it, who sort of are much more libertarian in their approach that, it's their right not to take this, etc.
Any other questions? There's one last question from online that Dr. Perl goes back to healthcare workers and the culture of coming to work sick. And the question is, what kinds of strategies have been effective in changing that culture, and also how it interfaces with a lot of strict absenteeism policies?
That's a great question and a loaded question. I mean, it really is. What we are seeing very much that's been part of the patient safety movement is a change in the culture where it's okay to tell people that, stop, this may not be safe for the patient, and simultaneously you're actually seeing people sort of say, stop, you shouldn't be at work, Charlotte, go home. It's people home. Right. And so I think that's changing, and that acceptance is changing, but again, it's going to require a sea shift. Now, the flip side of it, if you talk to the people who work in human resources, their challenge is that there are a lot of people out there who would love a reason not to come to work. And so how do you manage, that group? And I think that's the big challenge. So what we've done at Hopkins is we actually make them go get cultured because it determines how long you can stay out. So there is a little bit of a process. So if you don't come in to get cultured, then it's not an absence that is accepted or that we can say, this is appropriate. So that's happened more and more. But honestly, during H1N1, that we couldn't do it. There were so many people who were sick that we really just had to encourage people not to come in. So, and we didn't have vaccine at that time, so it was different. But I don't know that I have a good answer. I can just say that it's really a balancing act that many employers are struggling with.
Okay. Any last questions from the live audience? No? If not, thank you so much, Dr. Perl and Dr. Gaydos. And I hope that everyone will be back for our special grand rounds on October 4th and our regular grand rounds on October 17th. Thank you.